Dear listeners, this video is part 4 of the 4-part series on anatomy and physiology of the heart. For other videos, see Prescribon Medical Education series, Anatomy and Physiology of the Heart. The lower figure shows the semilunar walls of the aortic valve. The semilunar walls, both pulmonary and aortic, are especially strong but pliable. The following is the explanation for their strongly built construction. Aortic and pulmonary artery walls. The aortic and pulmonary artery semilunar walls function quite differently from the AV walls. First, the high pressures in the arteries at the end of systole cause the semilunar walls to snap closed, in contrast to the much softer closure of the AV walls. Second, because of smaller openings, the velocity of blood ejection through the aortic and pulmonary walls is much greater than that through the much larger AV walls. Also, because of the rapid closure and rapid ejection, the edges of the aortic and pulmonary walls are subjected to much greater mechanical abrasion than the AV walls. Finally, the AV walls are supported by the chordae tendineae, which is not true for the semilunar walls. It is obvious from the anatomy of the aortic and pulmonary walls, as shown for the aortic valve at the bottom figure, that they must be constructed with an especially strong yet very pliable fibrous tissue to withstand the extra physical stresses. When a person is at rest, the heart pumps only 4 to 6 liters of blood each minute. During strenuous exercise, the heart may pump 4 to 7 times this amount. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions, available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. This figure shows the electrical conductive system of the heart. The sinus node is in the upper part of right atrium. Connected to it is the atrioventricular node in the lower right atrium, followed by the AV bundle and its right and left branches and its distribution fibers to ventricles. We will see these in detail. The sinoatrial node, otherwise known as sinus node. The sinus node is a small flattened ellipsoid strip of specialized cardiac muscle fibers, about 3 mm wide, 15 mm long, and 1 mm thick. It is located near the opening of the superior vena cava into the right atrium. The fibers of this node have almost no contractile muscle elements. These fibers are 3 to 5 micrometers in diameter. Ordinarily, atrial muscle fibers are 10 to 15 micrometers in diameter. The sinus nodal fibers connect directly with the atrial muscle fibers so that any action potential that begins in the sinus node spreads immediately into the atrial muscle wall. Automatic electrical rhythmicity of the sinus fibers. Some cardiac fibers have the capacity of self-excitation, a process that can cause automatic rhythmical electrical discharge and contraction. This capacity is especially true of the heart's specialized conducting system, including fibers of the sinus node. The sinus node ordinarily controls the beat rate of the entire heart. The automatic rhythmicity is a function of the concentrations of sodium, calcium, and potassium ions inside and outside the cell walls. Internodal and interatrial pathways transmit cardiac impulses through the atria. The ends of the sinus nodal fibers connect directly with the surrounding atrial muscle fibers. Therefore, action potentials originating in the sinus node travel outward into these atrial muscle fibers. In this way, the action potential spreads through the entire atrial muscle mass and eventually to the AV node. The velocity of conduction in most atrial muscle is about 0.3 meters per second, but conduction is more rapid, about 1 meters per second, in several small bands of atrial fibers. One of these bands, called Bachmann's bundle, passes through the anterior, that is front walls of the atria to the left atrium. In addition, three other small bands curve through the atrial walls and terminate in the AV node. The cause of more rapid velocity of conduction in these bands is the presence of specialized conduction fibers. These fibers are similar to even more rapidly conducting Purkinje fibers of the ventricles discussed below. Atrioventricular node delays impulse conduction from the atria to the ventricles. The atrial conducting system is organized so that the cardiac impulse does not travel from the atria into the ventricles too rapidly. This delay allows time for the atria to empty their blood into the ventricles before ventricular contraction begins. It is primarily the AV node and its adjacent conductive fibers that delay this transmission into the ventricles. The AV node is located in the posterior wall of the right atrium, immediately behind the tricuspid wall. This picture shows the AV node which is connected to the internodal pathways above. The figures depict the approximate intervals of time in seconds from the onset of cardiac impulse in the SA node and its subsequent appearance in the AV nodal system. The right and left bundle branches are also shown. Now the details. We have already seen the parts of the AV node and the approximate delay time from the SA node to the AV node. This figure shows the different parts of this node plus its connections with the entering atrial internodal pathway fibers and the exiting AV bundle. This figure also shows the approximate intervals of time in fractions of a second between the onset of the cardiac impulse in the SA node and its subsequent appearance in the AV nodal system. Note that the impulse, after traveling through the internodal pathways, reaches the AV node about 0.03 second after its origin in the sinus node. Then there is a delay of another 0.09 second in the AV node itself before the impulse enters the penetrating portion of the AV bundle, where it passes into the ventricles. A final delay of another 0.04 second occurs mainly in this penetrating AV bundle, which is composed of multiple small fascicles passing through the fibrous tissue, separating the atria from the ventricles. Thus, the total delay in the AV nodal and AV bundle system is about 0.13 second. This delay, in addition to the initial conduction delay of 0.03 second from the sinus node to the AV node, makes a total delay of 0.16 second before the excitatory signal finally reaches the contracting muscle of the ventricles. The causes of the slow conduction. The slow conduction in the transitional, nodal and penetrating AV bundle fibers is caused mainly by diminished numbers of gap junctions between successive cells in the conducting pathways. So, there is great resistance to conduction of excitatory ions from one conducting fiber to the next. Therefore, it is easy to see why Each succeeding cell is slow to be excited. Rapid transmission of the cardiac impulses in the ventricular Purkinje system. We have already seen the Purkinje system figure. Special Purkinje fibers lead from the AV node through the AV bundle into the ventricles. Except for the initial portion of these fibers where they penetrate the AV fibrous barrier, they have functional characteristics that are the opposite of those of the AV nodal fibers. Purkinje fibers are very large fibers, even larger than the normal ventricular muscle fibers, and they transmit action potentials at a velocity of 1.4 to 4 meters per second, a velocity about 6 times that in the usual ventricular muscle and 150 times that in some of the AV nodal fibers. This velocity allows almost instantaneous transmission of the cardiac impulse throughout the entire remainder of the ventricular muscle. The rapid transmission of action potentials by Purkinje fibers is caused by a very high level of permeability of the gap junctions at the intercalated discs between the successive cells that make up the Purkinje fibers. Therefore, ions are transmitted easily from one cell to the next, thus enhancing the velocity of transmission. The Purkinje fibers also have very few myofibrils, which means that they contract little or not at all during the course of impulse transmission. The AV bundle is normally a one-way conduction path. A special characteristic of the AV bundle is the inability, except in abnormal states, of action potentials to travel backward from the ventricles to the atria. This characteristic prevents re-entry of cardiac impulses by this route from the ventricles to the atria, allowing only forward conduction from the atria to the ventricles. Recall that everywhere except at the AV bundle, the atrial muscle is separated from the ventricular muscle by a continuous fibrous barrier. See structure of AV node. This barrier normally acts as an insulator to prevent passage of the cardiac impulse between atrial and ventricular muscle through any other route besides forward conduction through the AV bundle. In rare cases, an abnormal muscle bridge or accessory pathway does penetrate the fibrous barrier elsewhere besides the AV bundle. Under such conditions, the cardiac impulse can re-enter the atria from the ventricles and cause serious cardiac arrhythmias due to inappropriately timed electrical impulses. Recall the cardiac conduction system. The AV bundle divides into the right and left branch. They pass along the ventricular septum and branch all over their respective ventricles. Distribution of the Purkinje fibers in the ventricles. Left and right bundle branches. After penetrating the fibrous tissue between the atrial and ventricular muscle, the distal portion of the AV bundle passes downward in the ventricular septum for 5 to 15 millimeters towards the apex of the heart. Then the bundle divides into left and right bundle branches that lie beneath the endocardium on the two respective sides of the ventricular septum. Each branch spreads downward toward the apex of the ventricle, progressively dividing into smaller branches. These branches in turn course sidewise around each ventricular chamber and back toward the base of the heart. The ends of the Purkinje fibers penetrate about 1/3 of the way into the muscle mass and finally become continuous with the cardiac muscle fibers. The total elapsed time averages only 0.03 seconds from the time the cardiac impulse enters the bundle branches in the ventricular septum until it reaches the terminations of the Purkinje fibers. Therefore, once the cardiac impulse enters the ventricular Purkinje conductive system, it spreads almost immediately to the entire ventricular muscle mass. Transmission of the cardiac impulse in the ventricular muscle. Once the impulse reaches the ends of the Purkinje fibers, it is transmitted through the ventricular muscle mass by the ventricular muscle fibers themselves. The velocity of transmission is now only 0.3 to 0.5 meters per second, that is 1/6 that in the Purkinje fibers. The cardiac muscle wraps around the heart in a double spiral with fibrous septa between the spiraling layers. Therefore, the cardiac impulse does not necessarily travel directly outward toward the surface of the heart, but instead angulates toward the surface along the directions of the spirals. Because of this angulation, transmission from the endocardial surface to the epicardial surface of the ventricle requires as much as another 0.03 second, approximately equal to the time required for transmission through the entire ventricular portion of the Purkinje system. Thus, the total time for transmission of the cardiac impulse from the initial bundle branches to the last of the ventricular muscle fibers in the normal heart is about 0.06 second. Spread of the cardiac impulse through the heart. Time lapse in seconds between the origin of the cardiac impulse in the sinus node and its appearance at each respective point in the heart. Right atrium 0.0 to 0.07, left atrium 0.06, right ventricle 0.18, left ventricle 0.18. Control of excitation and conduction in the heart. The sinus node is the normal pacemaker of the heart. The cardiac impulse normally arises in the sinus node. In some abnormal conditions, this is not the case. Other parts of the heart can also exhibit intrinsic rhythmical excitation in the same way as the sinus nodal fibers. This is particularly true of the AV nodal and Purkinje fibers. The AV nodal fibers, when not stimulated from some outside source, discharge at an intrinsic rhythmical rate of 40 to 60 times per minute. The Purkinje fibers discharge at a rate somewhere between 15 and 40 times per minute. These rates are in contrast to the normal rate of the sinus node of 70 to 80 times per minute. Why then does the sinus node rather than the AV node or the Purkinje fibers control the heart's rhythmicity? The answer derives from the fact that the discharge rate of the sinus node is considerably faster than the natural self-excitatory discharge rate of either the AV node or the Purkinje fibers. Each time the sinus node discharges, its impulse is conducted into both the AV node and Purkinje fibers. However, the sinus node discharges again before either the AV node or Purkinje fibers can reach their own thresholds for self-excitation. Therefore, the new impulse from the sinus node discharges both the AV node and Purkinje fibers before self-excitation can occur in either of these sites. Thus, the sinus node controls the beat of the heart because its rate of rhythmical discharge is faster than that of any other part of the heart. Therefore, the sinus node is almost always the pacemaker of the normal heart. Abnormal pacemakers. Ectopic pacemaker. Occasionally, some other part of the heart develops a rhythmical discharge rate that is more rapid than that of the sinus node. For example, this development sometimes occurs in the AV node or in the Purkinje fibers when one of these becomes abnormal. In either case, the pacemaker of the heart shifts from the sinus node to the AV node or to the excited Purkinje fibers. Under rarer conditions, a place in the atrial or ventricular muscle develops excessive excitability and becomes the pacemaker. A pacemaker elsewhere than the sinus node is called an ectopic pacemaker. An ectopic pacemaker causes an abnormal sequence of contraction of the different parts of the heart and can cause significant weakening of heart pumping. Another cause of shift of the pacemaker is blockage of transmission of the cardiac impulse from the sinus node to the other parts of the heart. The new pacemaker then usually occurs at the AV node or in the penetrating portion of the AV bundle or on the way to the ventricles. When AV block occurs, that is when the cardiac impulse fails to pass from the atria into the ventricles through the AV nodal and bundle system, the atria continue to beat at the normal rate of rhythm of the sinus node, while a new pacemaker usually develops in the Purkinje system of the ventricles and drives the ventricular muscle at a new rate somewhere between 15 and 40 beats per minute. After sudden AV bundle branch block, the Purkinje system does not begin to emit its intrinsic rhythmical impulses until 5 to 20 seconds later, because before the blockage, the Purkinje fibers had been overdriven by the rapid sinus impulses and consequently are in a suppressed state. During these 5 to 20 seconds, the ventricles fail to pump blood and the person faints after the first 4 to 5 seconds because of lack of blood flow to the brain. This delayed pickup of the heartbeat is called Stokes-Adams syndrome. If the delay period is too long, it can lead to death. Purkinje system causes synchronous contraction of ventricular muscle. The rapid conduction of the Purkinje system normally permits the cardiac impulse to arrive at almost all portions of the ventricles within a narrow span of time, exciting the first ventricular muscle fiber only 0.03 to 0.06 seconds ahead of excitation of the last ventricular muscle fiber. This timing causes all portions of the ventricle muscle in both ventricles to begin contracting at almost the same time and then to continue contracting for about another 0.3 seconds. Effective pumping by the two ventricular chambers requires this synchronous type of contraction. If the cardiac impulse should travel through the ventricles slowly, much of the ventricular mass would contract before contraction of the remainder, in which case the overall pumping effect would be greatly depressed. Indeed, in some types of cardiac dysfunction, slow transmission does occur and the pumping effectiveness of the ventricles is decreased as much as 20 to 30%. Implantable cardiac resynchronization devices are types of pacemakers using electrical wires or leads that can be inserted into the cardiac chambers to restore appropriate timing between the atria and both ventricles to improve pumping effectiveness in patients with enlarged and weakened hearts. Control of sympathetic and parasympathetic nerves on heart rhythmicity and impulse conduction. The heart is supplied with both sympathetic and parasympathetic nerves. The parasympathetic nerves, the vagi, are distributed mainly to the SA and AV nodes, to a lesser extent to the muscle of the two atria, and very little directly to the ventricular muscle. The sympathetic nerves, conversely, are distributed to all parts of the heart, with strong representation in the ventricular muscle, as well as in all other areas. Parasympathetic vagal stimulation slows the cardiac rhythm and conduction. Stimulation of the parasympathetic nerves to the heart, the vagal, causes acetylcholine to be released at the vagal endings. This neurotransmitter has two major effects on the heart. First, it decreases the rate of rhythm of the sinus node, and second, it decreases the excitability of the AV junctional fibers between the atrial musculature and the AV node, thereby slowing transmission of the cardiac impulse into the ventricles. Weak to moderate vagal stimulation slows the rate of heart pumping, often to as little as one half normal. Furthermore, strong stimulation of the vagal can completely stop the rhythmical excitation by the sinus node or completely block transmission of the cardiac impulse from the atria into the ventricles through the AV node. In either case, rhythmical excitatory signals are no longer transmitted into the ventricles. The ventricles may stop beating for 5 to 20 seconds, but then some small area in the Purkinje fibers, usually in the ventricular septal portion of the AV bundle, develops a rhythm of its own and causes ventricular contraction at a rate of 15 to 40 beats per minute. This phenomenon is called ventricular escape. Sympathetic stimulation increases the cardiac rhythm and conduction. Sympathetic stimulation causes essentially the opposite effects on the heart as those caused by vagal stimulation as follows. 1. It increases the rate of sinus nodal discharge. 2. It increases the rate of conduction as well as the level of excitability in all portions of the heart. 3. It increases greatly the force of contraction of all the cardiac musculature, both atrial and ventricular. In short, sympathetic stimulation increases the overall activity of the heart. Maximal stimulation can almost triple the heartbeat frequency and can increase the strength of heart contraction as much as twofold. Dear viewers, this brings us to the end of the videos on the anatomy and physiology of the heart in the Prescribon medical series.